join us as the hour moves along. Welcome, everybody. This is another installment of the IPA Virtual Journal Club, our International Journal Club. And thank you all for attending. My name is Rob Madden. I may know some of you. I am a geriatric psychiatrist in Toronto, Canada, and I sit on the Products and Services Committee for the IPA. And it's my pleasure to welcome everybody for another journal club. And it's my pleasure to introduce our journal club presenter today, Dr. Martin Orrell, who is the director of the Institute of Mental Health, which is a partnership between the University of Nottingham and Nottinghamshire Healthcare Foundation Trust, and head of the Division of Psychiatry and Applied Psychology at the University of Nottingham. Dr. Orrell has published over 300 academic papers. He's been awarded 7 major dementia care research grants totaling 17 million euro, and has led the development and evaluation of cognitive stimulation therapy for dementia. He's also a board member of Interdem, president of the European Association of Geriatric Psychiatry, which he and I were just talking about, and currently serves as an editor of the journal Aging and Mental Health. So thank you so much for presenting this paper today. And I think in terms of housekeeping, if you have questions, I'm going to keep my eye on the chat. This is going to be interactive. We'll have a presentation of the paper, but you feel free to put your questions, thoughts, feelings in the chat. Afterwards, we'll certainly have lots of time for discussion and interaction, not only about the paper, the methods, the critical appraisal, but the topic in general, and anything else that comes up, anything at all. So it's a good chance for us to just even informally chat about what's going on in our lives and that sort of thing. So we'll carry on. I'll keep an eye on the chat. Please, if you're not speaking, you may as well mute your microphone, and then when it's time for you to speak, you can unmute. Also, during the question and answer or discussion, you can use the raise your hand function, and your picture will go to the corner. Just to remind everybody about CME, we are accredited, and then our learning objectives, thank you. So it's really, by the end of the session, you'll be able to have an understanding of qualitative methods, understand social care challenges during the early stages of the pandemic, and be able to describe and understand the psychological impact of care withdrawal during the early stages of the pandemic. And we have no disclosures. Just to remind you of some upcoming dates. Our next journal club will be taking place at 7 p.m. Central Time on May 12th. And if there's anybody who's been coming to this who wants to present a paper, again, it's informal, it's low stakes, no pressure. We're all friends here. So if anybody would like to present, please contact me. And if not, I will find somebody for May 12th, but we don't have a topic yet. And just a reminder to watch your emails for any post-event evaluations that come your way. We do evaluate all of our talks, and we measure our outcomes to see if it's worth carrying on. But so far we've had good attendance for this. So without further ado, I feel like I've done a lot of talking. I'm gonna hand it over to you, Martin. Go ahead, and thank you.
Hi, thanks very much, Rob, and Denise. It's been really nice to be invited to present this. This is a really interesting paper. I liked it when I came in because I served as editor for it for the journal, and it was a really important topic and also really well written, which I always appreciate things if they're nicely written. And it's been of great interest to the readers. We've actually had 11,000 views and about 100 citations, and it came out last year. So I think it's something that's making people sit up and take an interest. Obviously, I don't need to fill people in on the background to the COVID pandemic. We've lived it for the last 2 years, but I think it's fair to say that the social care sector in the UK has been struggling for many years, and that just to let people know that when we're talking about care at home, they can have paid care, which can be privately or governmentally funded. and they may be getting some income support, and sometimes family carers can also claim something called attendance allowance, which helps to compensate them for their time. So it is means tested, and so like anything in relation to that, people are worried about something happening and them losing care, which of course is can be very serious. So people have already heard about concerns about things to do with people, dementia, pandemic. Social engagement is very important and related to well-being. I mean, it is for all of us, isn't it, really? I mean, maybe not absolutely everybody, but it's certainly something that's very key to life. And there's also worries about the extended social isolation that people felt coming up to the pandemic and since then. And there's impact also not just on people with dementia, but also on family carers who were supported through carer support groups and with other types of support, say in the UK through the Alzheimer's Society. So it wasn't just the people with dementia. And equally, there's the paid home carers who might be coming in once, twice, maybe up to 4 times a day, vital to helping keep people with dementia stay in the community, and part of the kind of integrated system. So there's also, of course, various types of services outside that, daycare, other types of social support, sometimes singing groups. So all of that was could have been, in fact, impacted to a great deal by the pandemic. But the main aim of this study was to look at the impact of COVID on social care and social support services, and look at how this affected the lives of people with dementia and unpaid carers, which largely is going to be family carers. So the people included were family carers of people living with dementia, or the people with dementia themselves. They recruited people from around the UK, particularly in the Northwest, from various types of social care and social support services. And it was funded by the University of Liverpool, who also provided ethical approval, and they gave them some money from their strategic fund. So it's an example, I think, of a university. I see Clarissa Giebel is one of the attenders, which is really handy if I get into any difficulties with the methods or the findings of the paper. So hi Clarissa. Clarissa is also now one of the editors of the journal more recently. So this is so they use a variety of channels, but it's a good example of doing research quickly in urgent times, newsletters, social media channels, etc. And they did telephone interviews, which were lasted up to 50 minutes during April 2020, so really at the peak of the first wave of the pandemic. And this was organised by Dr. Giebel, and also there was a variety of clinical psychology trainees, so people finishing their doctorate in clinical psychology. There was a topic guide, and they collected some demographic data, and also about how much time people had in terms of care and support before COVID, the hours of support, time since diagnosis. And one of the things they did was that we were looking at the qualitative studies. So for qualitative studies, I've got a handy heuristic, which is thinking of quantitative studies as providing associations and qualitative as generating meaning. So you need both in order to fully understand what's going on. So they had audio recordings transcribed into verbatim scripts by an experienced typist. They were anonymized and reread for accuracy. And they did a thematic analysis. So they were trying to fully immerse themselves in the narratives before coding. And then they were using a mixture of inductive and deductive thematic analysis. Now, don't think of myself as a qualitative expert, but I've done a bit of qualitative research and did a little bit of looking up on thematic analysis for information for this, but it's looking really at, it's not taking any assumptions to the data, but it's looking at the patterns of the data and then trying to interpret those. So you're looking for patterns of responses which are relevant to the research questions. And so you can use a mixture of inductive analysis, which is not having any particular frame of coding, but where you bring the data together and look for patterns. And also you can look at deductive methods, which is where you're bringing in preconceived themes. So inductive being a kind of bottom-up approach and deductive being a top-down approach. So what they did was this: they had 35 transcripts which were coded, and they had started with inductive theme analysis. So they're generating themes. This was discussed between the different transcribers. So they coded the transcripts using these themes, and then they did deductive thematic analysis. That's where they already have some idea of the themes, and to see how far they could be drawn out and complemented. Now, of note, and in terms of good practice in research, they included one person living with dementia and 3 people who'd been family carers as people with the research team. So they were helping to conceptualize the design, helping with the interview guide, making sense of the findings and dissemination. And so this is to try and ground the results of the paper and the interpretation in the lived experiences of those people who are affected. So in all, they had 50 interviews, with 42 with family carers and 8 with people with dementia. 3/4 were female, and most were spouses. And most people were living with the people with dementia. So we're getting the perspective of people who are kind of living in a kind of unit or a dyad at home, and trying to understand what was happening for them. So with the thematic analysis, they came up with 3 overarching themes about how COVID was impacting on people with dementia. And the first, with loss of control. So this was due to the drastic changes due to coronavirus, and people, I think, suddenly losing their support and their activities. One person said that their mother had 6 carers a day, twice in the morning, twice at tea time, and twice at night, to help her getting into bed, and had respite care herself when her mother went to the day centre. And then there was a local cafe that she went to, where there was a group, and there was a singing group. So the person had a lot of intensive care at home, and then also had some other groups that they went out to. So you can see it's a fairly, intensive level of support, but suddenly that went. So suddenly people were left to care at home. And sometimes if you have, for example, we call it double-handed carer support at home, sometimes you've got just one person now who's having to do activities, perhaps dressing and bathing, that might have taken 2 people before. And so one of the impacts was people's morale and a kind of shock and worry about what's happening next. And linked with this, there was the concern about the lack of mental stimulation. And people were commenting that, they thought, because of the changes that they'd seen in people with dementia, that they wouldn't be able to go back to how they were previously. There was a concern that there was, not being able to relate to people, not being able to do bits of shopping, being restricted to the house, and less likely to do any physical activity. One quote said, 5 weeks ago, my dad was a totally different person, and he won't come back. They also talked about all the other things and the friends that they had, and how they worried, actually, they wouldn't recognize couldn't remember the friends anymore, because it was only something that was happening week to week. One of the concerns was about paid carers, because obviously they were losing the input of paid carers, but there was a concern about lack of control, because on the one hand, if the carers were coming maybe with new restrictions on what they could do, they were worried about the carers bringing the virus into their home. So they were worried about not only loss of having their home care support, but who they could see. Were they going to have with the paid carers now bring the virus in, which might result in their relative getting really sick or even dying. But then if they turn down the paid care support for, I think 2 weeks usually. So if they didn't have it for 2 weeks, and if they were refusing it for 2 weeks, then there was a concern that they'd lose their care package. So they were between a rock and a hard place, if you like, in that they were worried about that there was the fear of the family care, of the home carers coming in, but also the fear of losing the support if they refused them. So one of the big themes also was uncertainty about what would happen afterwards. What would people be able to cope with? I've mentioned that people are saying, well, they basically forgotten the people that they used to see, only really remember them each week. The volunteers running the singing groups, and so they're worried about what will happen with the services coming back, but also about whether people would be able to do them or not, and a kind of running uncertainty, which has been with us all, about the changing public health restrictions, trying to make sense of what they were and weren't able to do, and particularly with people with more severe dementia, forgetting about the restrictions and perhaps being confined to the house because the family carer might be worried that they'd go out and they'd chat to people and talk to strangers or friends, but that they'd have human interaction, and that might expose them to the virus. So again, as I said, kind of between a rock and a hard place. Where the person was living in a care home, one of the things was about the being shut off from external contact. So they didn't know what was going on. They couldn't see them, and they couldn't engage with them very well. Telephone updates could be hard to get. So they might have been seeing the person every day, and suddenly they couldn't see them at all. And of course, for the person in the care home, very serious kind of social restrictions. And we know certainly in the UK, one of the problems was people with COVID who'd been in hospital being discharged to care homes while they were still infectious. So it was dreadful at some times in the early stages of the pandemic. So care homes were very, very tough places. And we'd even heard some stories in the pandemic of care staff living in the care home to try and protect the residents and just finding a way of spending time there. So being shut off from the normal environment, and some of the things was about what would happen with the new normal. We've had this new term, the new normal, and it was the person with dementia talking about forgetting about things because his partner gets all the stuff. So he's run out, so he could get the stuff if he made the inquiry, but he'd run out of eggs, he'd run out of milk, and he just needed to make a phone call. And other people talked about fighting the dementia. People talked about having a vendetta against his own dementia. And so actually trying to make the most of technology. Obviously at this stage, there was a, remote and technological support was something that was unfamiliar to many people, including, I guess, things like Zoom. I was hardly using Zoom myself 2 years ago. And so although there were benefits to being able to use technology, it wasn't a complete substitute for human contact. And things like a WhatsApp group could be very helpful for family carers. But sometimes there was issues that came up with people with rarer types of dementia, like posterior cortical atrophy, where the person couldn't really make sense of what was on the screen. So, in summary, this is one of the first studies to look at the experiences of people with dementia and unpaid carers during COVID. I think we've had a cohort effect in terms of use of technology, really, because people talk about older people and people with dementia not using technology so much, but we're coming into a cohort of people who've used technology before they develop dementia, and actually, so they're more likely to be able to use it when they have dementia as well. So we need to bear that in mind. But of course, it has been the pandemic has been a big accelerator to people using technology because it can provide some benefits, and they were, you know, quite often desperate to see people, and they couldn't see them in person. Some of the issues that came up in the discussion is concerns about the lack of mental stimulation. We're aware of things like cognitive stimulation therapy having benefits for people with dementia, but also concerns about perhaps behavioural changes for people who are isolated, depression and mood problems. And for unpaid carers, family carers, they'd have a particular routine, and then suddenly they had to take over care that was provided by paid carers. This could impact on their work, but also they may find themselves working from home as well as trying to look after somebody with dementia. So there's a lot of issues that came up, worries about faster deterioration, I've mentioned, worried about whether the activities would be running again and whether the person would be suitable. And I think the idea of breaking people's routine, which can be very, very helpful for people with dementia, and how they get back into it. As I mentioned, there were big issues around people with dementia not understanding, not remembering their public health restrictions. And my mother at the time of the early pandemic was in a nursing home for people with dementia, and again, very, very isolated from being able to have family visits, which is really makes you feel for them and be concerned about them. So I guess one of the issues I wanted to talk about today is our thoughts about what's it like, what's the difference between having a human contact where you're actually with people and you see somebody versus seeing people on screen. You know, where are we going with remote service provision? You might be aware there's been remote services in terms of cognitive stimulation therapy, but also there's been work on remote memory diagnosis and remote memory clinics. And again, different services have adapted quicker, whereas other people, because of an uncertain pathway, other services sometimes said, okay, well, we'll sit tight, perhaps the waiting list will build up a bit, but we can't do diagnoses remotely. So we've seen a lot of innovation and adaptation. And one of the, when this paper came out, there was lots of public health measures still in place. And of course, since then, we've had the rise of Omicron. So the public health changes have been very fast moving and constantly superseded. There were limitations on the paper, I guess, in terms of wanting to have more people with dementia involved in the interviews. I think getting 8 at the time that they did in the speed that they did was quite impressive. But I suppose particularly, and this is a running issue, the need for having more Black and other ethnic minority representation, particularly with concerns about the increases in the risks from COVID and the mortality. So looking ahead, we're thinking of how we can compensate for some of the lack of social interaction with flexible solutions and remote support, but not being sufficient kind of on its own. So I think this summarizes the impact of the paper in the early stages of the pandemic, and I'd like to wind up there and see what questions people have for me, but also for one of the authors if we're around. Okay.
Thank you.
Okay, Bob's picked up. Yeah, thank you.
Thank you so much. So if you have a question, you can go to reactions and raise your hand, and you'll move to the top left corner of my screen so I could call on you. You can put it in the chat, but we're all on one screen. So if you just want to unmute and talk, that would be great as well. So questions, comments, thoughts, reactions to this great paper.
Okay, well, I've got a couple. Sorry, Karen?
May I just say thank you, Martin, for presenting the paper.
Oh, thank you.
I was a bit apprehensive of joining journal clubs because hours at Liverpool can be quite harsh sometimes with papers. So it's nice to hear that. Thank you. It's certainly, when I looked back at the paper just now as well, it really feels like so much has happened in the past 2 years. It's still with us, the findings, but they've moved on in a way. But it's almost like a point in time where those findings were made, a critical point in time. So it's interesting to go back to it.
Thank you, Clarissa. I'm hoping that Clarissa's not been giving me marks out of 10 for my presentation on the paper. I guess one of the things that the paper made me think about was Kitwood's work on abnormal social psychology, in how there's stigma, and with the stigma people sometimes have social withdrawal, how people get talked over, and there's a process of kind of social disengagement and a lack of communication that then kind of impacts on people's, according to Kitwood's model, undermines people's cognition. And my own thoughts are around, the kind of excess disability. So actually, people can be functioning at the kind of optimum level. They have all this social interaction taken away, and then you're left with some excess disability. They're functioning worse than they would be in the right environment and with the right support. And I guess if you're thinking of a biological model, you might be thinking, okay, if you have this period of excess disability for a period of time, can you get back? We've seen people improve with medication for a period of time. Rob?
Yeah, so I put a comment in there. I was really interested in the public involvement, having unpaid carers form part of the research team. And I haven't seen it before, haven't seen it too much. And I wonder what that was like, if that's the standard thing that's being done now, and if that's done mostly in qualitative studies or quantitative studies, and what it was like, Clarissa, and what it added. Really curious about that.
Yeah, that's a great question. I personally think research wouldn't be valuable, that at least in our field, looking at the care angle, if they don't involve the people that are at the forefront and living those different problems, etc., because they really help us identify and focus on what they need us to look at as academics. So I love working with carers and people with dementia. We've noticed, obviously, because of the condition, some of the people with dementia that I've worked with in the past have unfortunately deteriorated further. So there's a constant need to obviously get more people with dementia involved, but also adapting the process of working with them. So it can be quite, I've had that the other day in terms of the Zoom links didn't work for carers and people with dementia, or them not often responding to emails, but obviously that's because they may forget, and we're so professionally, we have our professional hat on, so we think, let's reply to that email. But if someone is in a lived experience background, it's so different. It's just how we engage with people with those lived experiences. But I think it's been tremendously helpful and insightful having them involved. But there is obviously the limitation. So we've done this before the pandemic, where we invited people with the condition and carers to the University of Liverpool, have meetings, have chats over a cup of tea, and just talk about the research that we're doing, them being the team members as well. But now it's all Zoom or phone, and I'm mindful that that excludes some people further from shaping the research, particularly because my research mostly looks at inequities and inequalities. So that one is a difficult one, I think.
Can I pick that up? Because I think I echo what Clarissa said. In fact, actually, it's mixed in a way, because what some people have said in terms of public involvement is actually they like Zoom because it can be inclusive, and that the difficulty perhaps because of having somebody with dementia that they're looking after, the difficulty of actually getting from place A to place B and joining the meeting is such. And sometimes, particularly for people with disabilities, you know, if they had to come in a wheelchair or something like that, the fact that they can have some kind of engagement from home is really important for public involvement. It's becoming the standard for research in dementia care. And actually, we've even published guidelines on having people with dementia as peer researchers. So involving people with dementia in, say, helping to facilitate focus groups. And they obviously have some training. And there's also guidance now on the importance of including people with dementia and family carers in technology research, because there's been a big gap between the developers of technology and the use of technology. And one of the big problems is actually lots of really good technologies developed that people don't use because they're missing some of the things about what's needed. Also, technology can be exclusionary because it may be things like having to have a bank card, using a bank card, or trying to draw cash or things like that. So again, it's not a universal good or something that's always wrong. So one of the things I suppose about this is about the differences between having a relationship with somebody in person, where you actually see them, and actually talking to somebody on the screen. Somebody was saying to me yesterday, and it varies very much whether or not you've met them in advance. Because if you've met them in advance, you kind of have a feel for what they're like. And if you haven't met them, you don't have that necessarily that kind of rapport, but you're seeing them as a friendly face. Certainly I'm a friendly face on the screen. So I'm happy to, take people's thoughts around. I'm just looking at the chat again.
Yeah, there's a question from Dr. Rachel Carr, who is a subspecialty geriatric resident in Toronto. Rachel,
Excellent.
do you want to talk about your comment here?
Yeah, I was really interested in what you were saying about having the caregivers involved and people with lived experience with dementia themselves involved, and how it brings up different priorities, different questions. And I was just wondering if there was anything in particular that came up that wouldn't have necessarily occurred to you as being as much of a priority or a question, anything in particular?
It's a great question. I think so. It's kind of been a mix, because we also had lots of charity organisations involved in this from across the UK, as well as health and social care professionals. So it's really been the whole kind of spectrum of co-production and having people as equal team members. So they're just things. So because it was all so novel, and you hear it from discussions with other people, and you collect the data, but having, for example, charities involved who are telling you, we're having to furlough our staff, we can't deliver these support services anymore, I'm now running on one person, usually I have 5, or something like this. It's just to provide that background understanding, to really put it in context, what's happening. That's been so important. But also then being in those meetings and sharing those findings, and everyone helping to interpret the findings. So what does that mean? What can we do with that? So we know that's the issue now. What should we do about it? That's so important to have, as opposed to being an academic looking at it from the outside.
Oh, thank you.
I think just in relation to that, I think one of the things that struck me about the paper very vividly, but we may have experienced this, is the family carer who talks about, suddenly being the person who has to shower her mother, and being afraid to get too close because of maybe spreading the COVID virus. So this thing about suddenly the people you love can also bring, serious illness and death. So this is very, very traumatic, and I can imagine people probably felt on edge and that, you know, with the home carers coming in. And so we have to think back to what it was like for ourselves, I guess, but that world, understanding that world. Yeah. It looks like there's another question.
We have a
here.
question, and so Joseph, if you could maybe unmute your mic and turn on your camera, let us know where you're from in terms of where you are in the world, and ask your questions. Three-part question. Go ahead.
Okay.
Okay. I'll read the questions. So here we go. As the participants were relatively high, how do we judge, quote, how many are enough? So that's a good question in terms of, we're used to seeing power analysis. So if you want to get a significant result, how many subjects do you need in a particular study? So that's a quantitative study question. In terms of qualitative study, how many subjects are enough in a study like this? So that's question one. And I don't know if anybody can answer that question. Clarissa or Martin, please go ahead, unless there are others who have expertise.
Well, I'll start, and if that's okay. So normally what you're looking for, I mean, you're looking for a sufficient, to try and, sometimes this is done, and you try and keep going with interviews until you've found that you've kind of got the, you've got all the themes that might come up. So it's getting the diversity of the ranges of experiences. Now, you can't really say you can do that with one person, but I think you need a sufficient number to get the diversity and to kind of saturate the themes that you have. And conventionally, you'd estimate how many you might need for this, but potentially people might stop early if the same things kept coming up. So mainly it's about getting the diversity of themes that you need. I think 10 would be regarded as an absolute minimum, but I think the numbers that Clarissa's got would be considered sufficient to get a proper range of issues coming up, and also to illustrate because you need to illustrate the wide range of experiences people are having. Clarissa, do you want to add to that?
Yeah, absolutely. Echo what Martin is saying, and also thinking back, we had the same thing when we did our COVID care home study 6 months later. We were positively inundated with requests of people wanting to take part and sharing their experiences, because they felt there was absolutely no outlet to share these negative and traumatic experiences. So they wanted to take part, and conducting some of those interviews or reading some of those transcripts when other researchers have done them, they were pretty emotional. You are seeing some snapshots of those quotes. So, but yeah, that just in terms of sample size as well, there were so many diverse experiences expressed, and people really keen to share them as well.
There's another question that Joseph has around rigor around qualitative research. I think many of us are used to what would be rigorous in terms of a quantitative study, blinding, eliminating confounds, and that sort of thing. Rigor, how do you judge rigor for a qualitative study? And I think it has to do with the analysis, the way the thematic analysis is done. And I don't know if anyone can tell us more about how many people have to read a transcript, how it's done, how it's coded. It's complicated, but usually in the methods, there's coding, there's thematic analysis, and what does it all mean, and what brings rigor to a qualitative study, and is it even important? Yeah,
I think I might comment on that, because I think that I'm being asked to comment on Clarissa's study. So so I think that what they did in terms of having a number of people code it and then compare the codes for reliability, and then involving people with lived experience, that also adds to the validity of the findings. Did they make sense? Was there some kind of pattern between the different findings themselves? So I think that with those particular approaches, I mean, I think that is good in terms of rigor. Also, following a well-established methodology. And I looked up the Brown and Clark paper, which it seems to be the standard that people use now, which describes thematic analysis, and it's got 119,000 citations, which is like, wow. So I think they've used something which is, you know, the general go-to guide to how to do thematic analysis, and anything which has been cited as many times as that is probably a good, you know, it's probably a good yardstick for what you're doing. So I think that the combination of having a number of team members code it separately and then compare the codes, and then also having the public involvement, and then discussing the themes, you know, this adds to a kind of consensus type of vigor to the findings.
Joseph had part 3, and then we'll move over to Dr. Verhoof from Toronto. And as there's always contextual issues in performing qualitative studies, how did the role of policy of quarantine, example, stricter or looser regulations, influence the results?
Well, if I may take that. Well, the data were collected in April 2020. So that was, I suppose everyone was experiencing the first wave then, and pretty much complete lockdown, and no one knew. I remember the uncertainty I personally felt of, oh dear, what's this now? So I think, yeah, and we analyzed the data in May and June, I think, and then we submitted. So we were still in wave 1 and complete lockdown.
I think things would be different after 3 waves. So thank you, Joseph. We'll move on. And Joseph tells me he's from Taiwan, and it's the middle of the night there. But thank you for joining us, and we appreciate it. Dr. Verhoof, one of my colleagues in Toronto, go ahead. You have a question.
Right. Yes, just wrote down for the people with dementia. You basically described that they were like allowed to participate in the study if they would have mental capacity. That is quite a wide construct. So can you tell us a little bit more about how you determined which people with dementia were kind of allowed to enter the study and provide their input, and which people not?
Yeah, great question. So I suppose it's a 2-stage process that we did. First of all, people were contacting us if they wanted to take part. So we advertised everywhere, and only people living with the condition who are contacting us were then taking part. So that's, I suppose, the first step, them being cognitively able to engage with the information that's advertised and actually sending us an email or phone contacting us. And then second of all, we had a phone chat. Yeah, it was just phone at that stage. Where the phone chat about it, talked about the study, the information that we provide in an information sheet from Ethics Approved, and just went through it and just checked that the person living with the condition was able to retain the information and really understand what's asked of them, and also understand, for example, it's anonymized, you can withdraw at any point you like. That is, so we done it according to the Mental Capacity Act, assessed it. Does that answer your question?
Okay, yeah, that's fine, thank you. I just want to make a comment. I'm working in a memory clinic, and the themes that you actually described in the very first stage of the pandemic, seen throughout the months and years actually after this happened, really resonating with people we see in the clinic. So you're, I think, right on with some of these themes, and particularly also what Dr. Orrell described between this rock and a hard place, for example, having caregivers or not caregivers in the home with the risk of infection at home. For some people, it has been a huge issue, and they have actually been for months, some even more than a year, been muddling through without caregivers in their home, and until it became intolerable, became like impossible. Yeah, but I just can just compliment you on actually finding these themes, and just from clinical practice, as probably others also are attending the meeting, really acknowledging that these were like really important issues turning out to be like over the long run.
Thank you. That's positive to hear, but also incredibly sad to hear that it's just so common and ongoing. And that our worries in our team, we're now looking at, well, okay, we know that social care services, social support services have been so affected, and people haven't received the care for so long. They've not been cognitively, physically, socially stimulated for so long. What we're really interested in now is the long-term impacts of that on their mental well-being, but also in terms of care home entry. So it'd be really interesting to see whether there's an, I don't know, faster entry to care homes, for example, as a long-term impact.
I'd like to ask others who are joining the call if they've had similar observations or experiences with their clients and families, patients with dementia, whether they're outpatients or in a long-term care setting. What have people noticed in terms of their own experiences? So lots of people here seeing patients. Does it resonate with you as well?
I just comment. I mean, one of the things that has been a running theme, I suppose, for me and others, is disbelief. You know, it's still hard to believe that, that family members that you love so much that you shouldn't get near them, or you're not supposed to be near them for something. And I think what's been brought out by what Clarissa's been saying about people being very keen to tell their story is two things. I think one of the things is people often feeling like they've not been listened to, or nobody's heard them, the experiences they've gone through, and the effect it's had on them, and how traumatic and how profound it's been. And this is a big impact. But also it's the benefits of narrative and storytelling, and being able to tell your story to somebody who's going to listen and think about it and hold it in mind, and the value that this has. And I think this is particularly for people who are in the marginalized groups, and of course include people with dementia in that group, and family carers who might be very isolated looking after somebody with dementia. So both the power and the benefits of narrative, but also the feeling of many people who feel they haven't been listened to, and they need that outlet.
Can I add on this? I'm Faisal. I'm from the United States, from the East Coast, Michigan State. So in my small studies of the dementia people in Shanghai, we found, it can go both ways. During the outbreak of the COVID-19, the family caregivers, they have a high threshold for stress. They're less worried than the normal people because they're dealing with those high stress stuff all the time.
Yeah.
However, as the COVID pandemic continues, we found more incidents of abuse and neglect happening between close family members and people with dementia. Sometimes it's out of stress, out of frustration. They've been stuck there. China has a strict locking down policy. So that part has made a contribution to the high incidence of abuse and neglect in those families. Even suicide rates among people, not just people with dementia, even for older people, they're stuck in the high-rise buildings, cannot, get mobility. But I do have a question that piggyback on Dr. Bernhoff's point. I really applaud you having a person living with dementia and 3 caregivers involved in your study from the very beginning. We know it's very hard. We also do participant in a particular study. We have to accommodate their reading, their scheduling. It's very difficult. But my question is, more difficult for us in the US is we have to educate ILD. You just, Dr. Gabriel just mentioned how you determine the mental health capacity of the person with dementia. Here, we also in order to involve person with dementia, particularly at early stage or early onset dementia, we have to educate our ILB, which is Institutional Review Board, so that we can include person with dementia. We have to kind of go back and forth to even show video clips to educate them. I just wonder whether this is something IPA can do something to having a practical, or even the Journal of Aging Mental Health can do practical, how to involve people with dementia in research as not just as a participant, but as active, like a co-designer?
I think that's a very important point, and we do come across it in the UK, and this is I think fits in with the kind of paternalistic aspect of dementia, where this person is the looked after person. So it's also about othering them. So this person is the other. This is the person who has dementia, which is looked after. What people, and this is for your IRB, by the way, what people often don't recognize is that actually people with dementia are quite limited in how they can contribute to things. And research is one way in which they can contribute to society, and who they can actually give something of their own experiences. And actually, that's very valuable. People with dementia have altruism. They want to have a role in life. They want to do meaningful things. And sometimes contributing to research is a part of a limited range of things they can actually do. And actually, it's kind of amazing what ethics committees and review boards will come up with. But, you know, in England, people have a right to be involved in research under the NHS, and that also applies to people with dementia. The other thing I think that comes up in terms of capacity is, and, you know, we often get asked about this. I work as a clinical psychiatrist as well, but, you know, does this person have capacity? And the question is, capacity for what? You know, they may well have capacity to say that they'd like to be involved in a research study and talk to somebody about their views and their feelings, but not have capacity to decide how they're going to sell their house and, you know, how to put their financial matters in order and things like that. So, you know, so capacity is a wide range of things. It's capacity, it's specific, and you'll know this, I guess, everybody, but it's specific to the situation. And actually being able to say to people, you know, would you like to, you know, would you mind if we talk to you with a few questions about such and such? You know, the stakes are not that high. It's not like you're asking them about necessarily traumatic features from the childhood or financial details or things like this. It's actually things that are really important to them, and they have something to contribute. So that's my strong feelings about IRBs, you know, restricting access to research for people with dementia.
Thank you for comment. Just one quick question related to your paper. Have you found, I don't know whether you examined it or not, have you found in the communities that does dementia-friendly community initiatives, were there less impact of COVID or more access to service use among the participants who living in a community that has dementia-friendly initiatives in the UK, you know, among your participants? Because in China, when their community have dementia-friendly initiative, the service providers make initiative, proactive approach using technology, whatever technology that the residents are comfortable with, to reach out. So it turns out they increase their service use and support, even compared before COVID. Just wondering, for your sample, did you look at the community factors, like whether they live in a dementia-friendly community or those kind of available resources?
We didn't look at that angle and the neighborhoods and community factors. We did follow-up interviews 3 months later, and we already noticed that with a subsample of 20 people with dementia and unpaid carers, and we did notice already within those first 3-4 months of the pandemic that very, very gradually services adapted, some types of services, not all, to providing a little bit of remote support, especially what it depends within our NHS, within the different NHS in the UK, but many, when they get a diagnosis from a memory clinic, for example, afterwards there can often be a post-diagnostic support group, and we work with lots of clinical psychologists in Liverpool as well and beyond that do them, and we noticed as well that within those 3-4 months, they adapted to providing those support groups remotely, and other services started to adapt. But we also did a complementary longitudinal survey where we really wanted to track what type of services are being affected the most. And we found that paid home care, kind of picked up in the qualitative data, was the least affected.
Okay.
All the other services were most affected. And even after 6 months of the pandemic, which the survey captured, daycare, respite care, befriending services, support groups, they were pretty much on close to zero being delivered face-to-face. But paid care very slowly creeped up again over those 6 months, because then there was, I suppose, the adaptation to, okay, let's deliver it face-to-face. I hope that answers your question a little bit. So no, unfortunately, no dementia-friendly community angle.
Thank you. I'm just looking at the chat, and I apologize if I pronounced the names wrong. Is it Joris or Joris Vlamnik? And I see you turn on your camera. You're saying the findings are similar to Belgium. Did you want to tell us more about what you're finding there?
No, my English is not very good, but I found when I read this article, I can I find the same situation in Belgium. There's everything first in the first Gulf, everything was down. And what Clarisse Giebel say, the paid help is never stopped. That's a difference.
Yeah,
it's never most of the. But we have. I working in a memory clinic as a nurse, but there were a lot of people who be afraid for coming to the clinic. There was no problem that they coming, but they were afraid for coming because of the virus. And in the second and the third and the fourth wave, we seen that they were not so afraid for coming to our paid services.
Thank you.
Excuse me for my language.
Oh, thank you. Thank you.
Rob, I was going to pick up something from an earlier point from Faison, which is, I guess, the people are talking about the kind of impact on carers. And I think in some ways, you know, people have been through an experience which is you're similar to the experience of dealing with grief, in that there's, you know, shock and denial, distress, and at some point kind of adaptation. And I think for certainly in the UK in the early stages of the pandemic, I think there was a very strong belief that it wouldn't last very long. And there was kind of what you might call a wartime spirit, that people were clapping the NHS every Thursday night for what a great job they were doing. You know, it wouldn't last too long. We'll have restrictions. We'll get over it. But I think particularly for family carers, in you know, people are going through a process of adaptation and trying to come to terms with things. And if they think, you know, that they can, you know, just up a couple of gears and manage for a few months and then it'll all be all right again, there's going to be a period in time when actually they realize maybe it's not going to be all right again after a couple of months. And, you know, God knows how long it'll be. So that's, I think, when they start getting into that, you know, with changing expectations, that when it can be very traumatic, and we talked about abuse. And the other thing I think to bear in mind is, you know, a lot of people, family carers, but also people with dementia died during the pandemic. So if you've been, the impact on people, if they've been a one-to-one carer for many years, which has taken up a large part of their life, but then the person goes to hospital or care home and dies, and then they're still in isolation, but without that other person who was so crucial. I think that's had a very huge, you know, huge impact on people. And we must, you know, recognize the great hole in family carers' lives quite often when that person goes to a care home or dies.
So I'm just mindful of the time. Thank you. And I want to end here. I think it's the hour is up. It's amazing how fast an hour flies by. Thank you so much, Dr. Orrell, for participating and presenting today. We're very lucky that you participated, and our guest Clarissa Giebel.
I can see you, Clarissa. Yeah.
We hope it wasn't as aggressive and critical as Liverpool, and we try and be very nice.
This is like a Reviewer One Journal Club here. It's very nice.
Please come back, Clarissa. Please come back. We'd love to have you. Please keep your eyes open for an evaluation form from the IPA. And if you've enjoyed this today, please tell your friends and colleagues so that we can have more participants. So thank you all. Have a great day, and thanks to our presenter. Thank you, Martin.
Thank you very much. Very nice. Thank you. Nice to see you all. Thank you, Clarissa, also. Yeah. Bye-bye.